Welcome to PT Microlessons, fast lessons with big impact. In this lesson, we'll look at medications used to manage hypertension. We'll focus on how the major drug classes work, and most importantly, the key considerations for physical therapy practice. When lifestyle changes alone aren't enough to control blood pressure, medications are often used to help reduce the workload on the cardiovascular system and lower the risk of complications. We'll focus on 5 major classes of medications used to manage hypertension: diuretics, beta blockers, calcium channel blockers, RAAS blockers, and vasodilators. Although they work in different ways, they all ultimately reduce blood pressure by decreasing blood volume, reducing the heart's workload, preventing vasoconstriction, or promoting vasodilation. For each class, we'll briefly look at how it lowers blood pressure, and most importantly, the key considerations for physical therapy practice. Let's start with diuretics. Diuretics act on the kidneys to decrease sodium reabsorption and increase water excretion. By removing fluid from the system, they reduce blood volume and help lower blood pressure. For physical therapists, watch for orthostatic hypotension and signs of fluid depletion or dehydration, particularly during exercise and mobility. Diuretics can also cause electrolyte imbalances, especially changes in potassium, which may contribute to muscle weakness, cramping, or cardiac rhythm disturbances. Next, beta blockers primarily act on the heart by reducing the effects of sympathetic stimulation. Normally, the sympathetic nervous system increases heart rate and contractility, helping increase cardiac output and blood pressure. Beta blockers reduce this response, decreasing heart rate, myocardial workload, and oxygen demand. For physical therapists, one of the most important effects is a blunted heart rate response to exercise. Because heart rate may not increase as expected with activity, RPE can guide exercise intensity. Also monitor for bradycardia, fatigue, and reduced exercise tolerance. Normally, when blood pressure or blood volume drops, the body activates the renin-angiotensin-aldosterone system, or RAAS, to help restore blood pressure. The end result is increased angiotensin II activity, which causes vasoconstriction and promotes aldosterone release. Aldosterone increases sodium and water retention. So in simple terms, RAAS raises blood pressure by constricting blood vessels and retaining fluid. So, what we are calling RAAS blockers are drugs that interfere with a step in the renin-angiotensin-aldosterone system. But the overall effect is similar: less angiotensin II activity, less vasoconstriction, and less aldosterone-mediated fluid retention, ultimately lowering blood pressure. The most common are angiotensin-converting enzyme, or ACE inhibitors, which block the enzyme responsible for converting angiotensin I to angiotensin II. Angiotensin II receptor blockers, or ARBs, block angiotensin II from acting at its receptors. Direct renin inhibitors act earlier in the pathway by blocking renin activity. For physical therapists, watch for orthostatic hypotension and hyperkalemia. ACE inhibitors can also cause a persistent dry cough, and less commonly, angioedema. Okay, now let's look at calcium channel blockers. They primarily act on blood vessels, although some also affect the heart. By decreasing calcium entry into vascular smooth muscle, they promote vasodilation and reduce peripheral vascular resistance, which lowers blood pressure. For physical therapists, watch for orthostatic hypotension and lower extremity edema. Because these medications cause vasodilation, use caution with systemic heat, which can further promote vasodilation and potentially contribute to hypotension or dizziness. Lastly, like calcium channel blockers, vasodilators lower blood pressure by relaxing blood vessels and reducing peripheral vascular resistance. The difference is how they produce that effect. Calcium channel blockers reduce calcium entry into vascular smooth muscle, while direct vasodilators act more directly on the smooth muscle to cause relaxation. For physical therapists, the concerns are similar. Watch for hypotension, particularly with position changes or exercise, as well as reflex tachycardia, headache, dizziness, and lower extremity edema. Because systemic heat can further promote vasodilation, use caution when combining heat with these medications. Okay, let's wrap up with the key takeaways. Antihypertensive medications lower blood pressure through different mechanisms, but many share effects that are important during physical therapy. Orthostatic hypotension is a common concern across several classes. Beta blockers can blunt the heart rate response to exercise, making RPE particularly useful for monitoring intensity. Diuretics and RAAS blockers can affect electrolytes, while medications that promote vasodilation may contribute to dizziness, hypotension, or edema. Ultimately, know the medication class and monitor the patient's blood pressure, symptoms, and response to activity. That's it for this PT Microlesson. Like and follow at PT Microlessons for more fast lessons with big impact on physical therapy topics.